Hi everyone, this is Dr. Madhusudan Rao. On the program, I teach medical students. Today's topic is hypernatremia. In this class, we touch briefly on the definition of hypernatremia, causes, and pathophysiology. When the serum sodium levels are more than 145 milligrams per liter, we call it is hypernatremia. Sometimes with the serum sodium level 150 milligrams per liter is also considered or defined as the hypernatremia. Most commonly, we consider serum sodium levels more than 145 milligrams per liter as hypernatremia. Hypernatremia is rather less common than hyponatremia, and in children suffering with hypernatremia, they look more ill. It is estimated it is nearly 3% of the hospitalized patients they suffer from hypernatremia, and it occurs in 9% of the patients in intensive care units. Etiology and mechanism are heterogeneous. So, what are the etiological factors? They can be divided into causes with water and sodium loss, causes that result in pure water loss, and those associated with the increased total body solute or excess serum sodium. So, in all these groups, what is happening? There is more serum sodium levels when compared to the water. That results in the hypertonicity of the extracellular compartment. This results in shift of water from the intracellular compartment into the extracellular compartment. As the intravascular fluid is maintained well, renal perfusion is maintained, and clinical presentation of the patient will be delayed because symptoms appear late. This is very dangerous because the patient presents with complications and they suffer from high degree of mortality. The most important devastating complication, as I remember, is the cerebral hemorrhage. So we'll touch the clinical manifestations and the complications later in course of the topic. Now coming to the causes of hypernatremia. Those associated with water and sodium deficit. Here, water deficit is more than the sodium loss. So the conditions can be conditions associated with the reduced water intake, the conditions associated with excess loss of water. So whatever may be the cause, there is hypertonicity or hypernatremia of the extracellular fluid. That is excess solute in the extracellular compartment. Reduced water intake could be in neonates on breastfeeding, children with neurological disorders where there is reduced water intake, children with mental retardation, those in intensive care units, and those with on intubation. The conditions associated with excess loss of water. The loss could be through skin, during fever or exercise. Loss could be through gastrointestinal tract due to viral diarrhea. And there could be renal loss of water secondary to diuretics, diabetes insipidus, etc. When there is excess loss of water relative to the sodium, it results in hypernatremia. And in cases of diarrhea, the patient loses hypotonic fluid, resulting in hypertonicity of the intravascular compartment. Because diarrheal fluid, so 35 to 60 milliequivalent of to liter, as it is hypotonic. So patient will be losing hypotonic fluid in diarrhea, resulting in hypertonicity of the extracellular compartment. What are the conditions with pure water loss? So patients with diabetes insipidus, which could be nephrogenic or central. Patients with increased insensible loss of water. That means there is loss of water through skin, especially in premature babies, babies on radiant warmer, babies on phototherapy, babies with inadequate breastfeeding, or those on abuse. In all these conditions, say for example, in renal conditions, for example, in diabetes insipidus, there is no response to antidiuretic hormone. That means renal tubules, they do not respond to antidiuretic hormone. So there is loss of water, excessive loss of water through urine. That results in water deficit with retention of solutes. In conditions again associated with the excess loss of water through skin, okay, which occurs in the premature babies as they have the more surface area related to body weight. That results in the deficit of water with retention of solutes, consequently hypernatremia. So what are the conditions associated with excess sodium? Total body content of the sodium is high. This situation occurs in hospitalized patients who are treated with a normal saline when they present with pure water loss. The patients are admitted to dehydration secondary to water loss, but they are treated with normal saline, and that leads to hypernatremia due to excess of sodium. And patients treated with for hyperkalemia with hypertonic potassium solutions again results in hypertonicity. When the patients with raised intracranial pressure are treated with hypertonic solution, again results in hypernatremia. And administration of sodium bicarb, concentrated formula feedings, and chronic excess sodium intake results in again to hypernatremia. Patients with hyperaldosteronism, there is excess retention of sodium and loss of potassium, ultimately resulting in hypernatremia and fluid overload. This is in brief about the definition of hypernatremia and the causes and the underlying pathophysiology. Well, we'll conclude today's talk at this point. Thank you very much for patient listening. Subscribe to my channel if you like my video, and we meet again in the next class. Until that time, bye bye.